Hello, and welcome to RT Sidebar, a podcast by respiratory leaders for respiratory leaders. Today's show is a live recording from 11 January with guest Dr. Wes Ely, author of Every Deep Drawn Breath. Our host will be diving into how you can lead change in your organization as well as the ABCDEF Bundle. This is RT Sidebar. Stay tuned. Hi, everybody. Thank you so much for joining us today. We are so excited about this show. If you're a new listener or you're just joining us today, I'm Anna Hayes. We had a podcast episode, Voices of AARC, where multiple people stopped by our booth and we had one question: what's your takeaway from AARC? And they said, Dr. Wes Ely, the author of Every Deep Drawn Breath. So we have him here on the show today. We're going to learn so much from him, which is so exciting. Our big takeaway from this was not just powerful patient stories and how to care for the patient and the patient's family post ICU recovery, but also in the ICU. We were like, wow, there's so much here on change management and how to get buy-in. So that is where we're going to start. So this is RT Sidebar. Thank you, guys. We will have this open to questions at about 4:45, but you can enter and comment to the side here. You click the chat, and we'll keep the sidebar and the discussion going, which I will specify again as we have new people joining us as this is rolling along here. To all of our listeners, catch our live recordings by going to vtherm.com/RT sidebar to register for future ones. So, all right, Matt, take it away. Please introduce Dr. Ely further.
So, Anna, as always, our writer, producer, herder of cats, you are the best. Thank you so much for getting us ready for the RT Sidebar. First off, I want to say thank you, Anna. I also want to say thank you to our guests. We got some heavy hitters here. We got Dr. Wes Ely, who are here. Kaylee Dayton, thank you so much for joining. We really appreciate you. And then Dr. Whittle, Alicia, John, we got Matt, we got Taylor. We got awesome people on the sidebar today. Super, super excited to talk about this book. And I got to tell you, this book was awesome. I talk about this book, I think about this book, and I'm not saying because Dr. Ely's right here. It connected me to being an RT again. And I've been a hospital administrator way too long, and I forgot what it was like to be at the bedside. So, Dr. Ely, before we even get anywhere, thank you for helping me connect there, because I needed that. It made me feel good, but it also reminded me that healthcare still needs some fixing. So first off, I want to introduce Dr. Wes Ely. He is pulmonary critical care medicine at Vanderbilt. He's a professor of medicine, division of allergy, pulmonary critical care, pretty much anything in medicine you could think of, he has behind his name. So Dr. Ely, I really appreciate that. But what his research is focused on is improving care and outcomes of critically ill patients. I remember being an RT. Everybody was snowed. We took care of them. We hope that they wake up, but we really didn't think about what it was when they got outside of the ICU. Hey, I did my job as an RT with my pulmonary friends and my nurse friends in the ICU. And what happened afterwards, that's somebody else's problem. But what Dr. Ely starts to talk about is critical illness, brain dysfunction, survivorship. What does that look like after the ICU? And one of the important things, and what I want to go into, which I think is more important than anything else, is you will be affected by ICU in your lifetime. You will. Every single person will be affected by the ICU, and you will not come out the same. And you hope that damage is minimal. So I'm going to go right to Dr. Ely. First off, why did you write this book, and who should read it?
Secondly, thank you so much, Matt. I appreciate you, Anna. I appreciate you and all the audience here. Thanks for giving me a little time just to be with you. It's such a gift to me as an ICU physician to connect with all of you who are at the bedside with these patients. And one thing you just said, Matt, made me think of this area, and I just pulled this excerpt up from Every Deep Drawn Breath. Delirium changed people's brains and altered their lives. This is me reflecting on what I, as a young non-gray-haired physician, I just finished describing Teresa Martin, and above this in this chapter, I'd written, she'd lost her spark. She was such a personality pre-illness, so gregarious, and really the life of the party, but she's very flat now. She has memory problems, some long-term, mostly short-term. She doesn't remember anything about her illness or her hospitalizations. She looks much older now. She's fragile and vacant. And then I go on down there to reflect, delirium changed people's brains and altered their lives. And think as respiratory therapists of being there, or nurses being there with your patients at the bedside. They come in one way into the ICU and they leave heading in a completely different direction. One day they're living their full lives, and the next day they're clinging to the railing, barely holding on to their memories. I imagine that an MRI would have shown Donna's brain to have the same atrophy as Sarah Beth's, or worse. These are real people that I'm describing in the book. I thought of Donna and Sarah Beth, and I remembered Teresa Martin all those years before, the young woman who had returned to my care in a wheelchair, 24 years old. Her befuddled thinking and limited life after the ICU made sense to me now. I was sure that if I found her medical file, the notes would include ICU psychosis and no mention of delirium, because we didn't used to think of it like that. We thought of, oh, their brains are going to go away for a while, but we'll take care of their lungs, we'll get them better, and then we'll come back and fix all that. And there's one more place, I'm just going to read one more little short thing, and then we can open it up for conversation. I write later on in the chapter entitled Unshackling the Brain. As physicians, nurses, respiratory therapists, we generally think we are most likely to harm our patients with an errant scalpel, a central line placement gone awry, a medication error, or ventilator management. But sometimes we cause more harm by blindly accepting usual practice as best practice. Familiarity breeds complacency. And I think this is what happened in critical care. And I refer to this, Matt, as a malignant normality. There's a malignancy about accepting usual care as best care when we can do better for these patients. So what are your thoughts about any of that? And that's what made me write this book, was let's write real patient stories, wake ourselves up, and do something different.
Wake ourselves up it could have been the title of your book as well, because it's not only waking your patients up so they're not snowed and go into delirium, it's waking us up as healthcare providers. So malignant normalcy, holy cow, what a word. And we always say it in respiratory, well, we've always done it that way. Well, why'd you get that neb? We've always done it that way. Why'd you in the ventilator that way? We've always done it that way. I think questioning the norm is true innovation. That's true innovation. And I love that you're questioning that. What I have to ask, and the part as a respiratory leader, this is a respiratory leader podcast. Dr. Wes Ely, you had a thought in your head, delirium is bad. The norm is bad. But everybody around you said it's perfectly fine. How did you manage that conversation?
You know, let's go back and I'm going to answer your question. Let's do this through history. Okay. When I was a young doctor in the 1990s, not gray-haired, and I was taught this is how you do critical care. Everybody's on a Versed and fentanyl drip, or Versed morphine drip. Everybody's going to be immobilized, because guess what, Wes? That's what's kind. That's benevolent, is to keep them immobilized and sedated like that. And, you know, in medicine, we think that benevolence is our goal. It's not. Benevolence is wishing good. Beneficence is the right goal. That's actually doing good. And it may be well intended to keep somebody sedated and in the bed like that, but it doesn't actually do them good. It does them a lot of harm. So back in the 90s, I just wanted to go in academics, and I thought there's got to be a better way to standardize respiratory care than every single patient getting treated differently. Some are getting weaned with pressure support, some are getting weaned with IMV, and it's just all over the place. So all we did was design a very simple randomized controlled trial that allowed the respiratory care practitioners the decision-making capacity. The respiratory care practitioners screen the patient, see if they have a good rapid shallow breathing index. And if they do, give them a spontaneous breathing trial. And guess what? If they pass that SBT, put that note in their chart that says your patient now has an 85% chance to stay off the ventilator for 2 days, and let's see what happens. And people thought, this is a dumb idea, Wes, it'll never work. Well, guess what? It shaved 2 days off the ICU stay, off the ventilator time. It shaved $5,000 off per patient in care, and it cut complications in half. Okay, that was in the New England Journal of Medicine, and that's when we started using SBT, spontaneous breathing trials. Only a few years later, JP Crest did the same exact thing with spontaneous awakening trials. And these were the two studies that really started to shift our thinking that waking people up and turning the ventilator off is way safer than leaving them on it. And then in 2008, we put the two tools together, published it in the Lancet, and showed for the first time in all of critical care, turning the drugs off, turning the vent off, that's called the ABC approach, awakening and breathing control trials. That actually saved lives, not just time, not just money, but actually a 15% reduction in the likelihood of dying. And that's how we built the ABCDEF bundle. We did it with evidence, we did it with randomized trials, and then we started trying to change care. And we knew, Matt, that we had to get data to prove it to people, because people won't change without strong evidence.
So I grew up as a respiratory therapist in the 90s as well. And I remember I'm a neo-Peds guy by training, but as an adult, they're like, hey, we're just going to turn off the ventilator and see what happens. I'm like, are you crazy? We need to be SIMV. It needs to go from 10, and then I need to go to 8, and it needs to go to 6. And when it gets to 4, I'll make somebody call. It took me to realize that ventilators are bad, get them off. End of story. And I will tell you what changed my mind. I was at a conference in Washington, and this is probably 2002. I was giving probably one of my very first lectures of my career. And a pulmonologist, just like you, said, ventilators are death machines. And everybody's face went, oh my God, how could you say that? They're life-saving machines. And he's like, if you stay on it long enough, it will kill you. And that's the moment that changing with SBTs and SATs, that's what changed my life. But you had to have the data, and you have incredible data. And to be honest, we all do ABCDEF Bundle because of some of the work that you've done. But it was tough.
I love the fact that you're saying that we all do it, but we know that unfortunately we don't do it well enough. And COVID kind of pushed us in the wrong direction, of course. I would like to talk about, what are the things that stimulate change? And I know Kaylee Dayton, you're here. You're a very seasoned ICU nurse. Kaylee, what's happening in your brain right now as you're thinking about this? I just would love to get a little 2 cents from you about as an ICU nurse, about what's happening at this point in the conversation.
Oh, it's all really familiar. Just the normalcy of everything that is going on out there. When I started my ICU career, I started in what I call now an awake and walking ICU, where it still is the opposite of the rest of the ICU community. Most patients, unless they have an indication for sedation, they are allowed to wake up after intubation, and they're mobilized within hours, usually, of that intubation. And they continue to be awake and mobile throughout their time on the ventilator, unless there's a contraindication. And so I thought that was critical care medicine. I thought it was normal to have patients cruising through the hallway, dancing, shimmying on the ventilator, sitting in the chair throughout the day, communicating, calling the shots. And then I became a travel nurse, and I went elsewhere. And my first contract, I remember just feeling like a different ambiance in the unit. Everything was dark. Every single patient was in bed. There was very few signs of life. And I got my first assignment, and I asked my orienting nurse, hey, can I take sedation off and get them up? Because I didn't know why the patient was sedated. I was just making sure that there wasn't an actual reason for it. And she looked at me in shock and said, what? No, they're intubated. And that was the first time after years of critical care medicine that it had ever crossed my mind that sedation would be mandated for someone just because they were intubated on mechanical ventilation. And that was the beginning of years of travel nursing. And I found that normalcy of having every patient in a medically induced coma while on mechanical ventilation was the norm throughout the ICU community, that I was alone in my perspective. And unfortunately, as a nurse, no one had taught me why we did those things in the wake and walking ICU. No one had said, hey, here's what sedation does. Here's what immobility does. Here's why we keep patients awake and moving. No one explained that to me. So I didn't have the tools to defend myself and to combat that normalcy with the evidence until years later when I started doing my own research, which turned into this podcast that I do now. So listening to this, now that as a consultant, I'm working with ICU teams, I'm constantly trying to find that normalcy. And I'm so grateful for Wes's research, because that's what I utilize to combat the culture by using evidence.
So this malignant normality really is super dangerous. And just for the listeners, I just want to tell you that what we did was we built individual randomized controlled trials to build each letter of the ABCDEF bundle. And then we tested them all together, and we have data in over 30,000 people with the full ABCDEF bundle, the 6-step safety bundle, showing that the higher compliance you have with the bundle, the less the death rate is, the shorter the ICU and hospital length of stay are, less ICU bounce backs, less delirium and coma, and less nursing home transfers. But let me read you one more thing. There's another place in the book where there's a nurse named Jet. Her name is Marianne Barnes-Daly, but she goes by Jet. And this is 2 paragraphs. I interviewed everybody for every deep drawn breath, and I used this little device here to record their interviews, and I transcribed them. So all of them are real words that people actually told me. I tried to be an investigative reporter about it, essentially. Jet told me how she approached changing the culture of critical care within her hospital system. By the way, this is a nurse who published a 6,000 patient study showing the evidence behind the bundle. She was the first person to prove in a multi-center trial, it was 8 ICUs in California, that this worked in a multi-center trial. And so she said, quote, I went to the ICU in my small hospital and I told them about the bundle. Here's A and B and C. And I explained everything, and the nurses nodded. I said, so this is what we have to do. This is the new cool stuff. They said, great. 2 weeks later, I went back, and you know what they had done? Nothing. Jet laughed. I can imagine she didn't laugh at the time, though. Trying to sell people a mortality reduction isn't really meaningful to them. You have to sell patients stories. That was exactly what we had learned, too, with the Institute for Healthcare Improvement, the IHI. You must sell stories to get people on board. One more paragraph. Jet went on. I went to our flagship hospital, Sutter Medical Center, where there was an ICU nursing meeting. They had to be 60 or 70 nurses in the room. I had an hour. I spent 40 minutes telling them how we were hurting people, and 20 minutes how we were going to fix it. I told them what sedation did. I told them what tying patients down in bed did, how they couldn't walk, or how their jobs, or how they lost their spouses and their families, how they'd said that they'd rather be dead. I had nurses crying. They thought they were doing the right thing. Respiratory therapists too, because that's what they'd been taught. They said, we didn't know. I said, I didn't know. I'm learning all this stuff too, but we're hurting people. We're breaking their brains.
That is powerful to me. Okay. So, Wes, Dr. Ely, you and I in the 90s grew up, sedate everybody because that's what we as clinicians felt was right. Kaylee's norm is completely different. Her norm is this new presence of data that drives her practice. So one of the questions that Jeff asked is A through F bundle universally adopted? And
okay.
unfortunately,
so we have data. Let me tell you some data. I always like to be data driven here. Before COVID, we did a study in 40 countries, Jeff. And in those 40 countries, and we published this paper in Intensive Care Medicine, so it's a peer-reviewed paper, we showed that there was a variety of the degrees of implementation. But in those 40 countries, the average implementation of the bundle was probably about 60%. Some areas of the bundle were in the 80 to 90% range, and some were in the 40% range. But yes, across 40 countries and all those languages, generally, this was accepted as what we should be doing, but there were some limitations. Now, once COVID hit, we redid those numbers, and we found that the bundle was about 10 to 20% during COVID. So it plummeted during COVID. Why? People were behind glass. We didn't have vaccines at the beginning, and we didn't have PPE. So people were afraid, and out of fear, they left the patients in the room on the blower, in the bed. I don't want them to extubate, self-extubate, so I'm going to leave them sedated. And so we're now in a rebuilding phase, Jeff, to make people realize We don't have to reinvent the wheel here. We know what works. We know what saves lives. We have the data. Let's just teach these young COVID nurses, COVID therapists, COVID doctors who it's not their fault. They just came into the pandemic and they were taught this erroneous way to care for patients. So we have to unteach them. They have to unlearn.
So this is amazing to me. And Kaylee, I know we're going to have you on the podcast because I can't wait to talk to you about the RN perspective. But I know this for a fact, as a bedside respiratory therapist and as a respiratory therapy director, the ambulation piece is probably the closest to zero, because walking a ventilator patient is scary. Okay. As a NICU therapist, kangaroo care is scary. Moving a patient that has a tube in their mouth is scary, but yet it has great evidence to prove you're going to get off the ventilator and actually go home more intact. And I think, Dr. Ely, what I learned a lot from yours is I came with a pneumonia and now I have a neurologic problem. I came with a COPD exacerbation. Now I have a collapse. That we do the very best. We want to do the very best, but do we do it? So I'm going to go to both of you. The downfalls of healthcare can sometimes outweigh the good. How do we balance that? Because beneficence and non-maleficence are a balance. So yes, in your practice, how do you have those conversations with your patients and family? Because you know bad things can happen. And Kaylee, I'd like to have your perspective as well. So Wes, please go first.
Yeah, what happens in my brain when you ask that question is this. Are we being driven in our behaviors and care patterns at the bedside by what we think is convenient to us, or by what's actually better for the human being that we're there to serve? And if I continuously remind myself that I'm not there for me, I'm not there to make it easier on me, I'm not trying to keep the sheets perfectly clean and straight on the bed. You know, that's a fallacy. Why should the nurse's bed have to look so tight and nice like that? If the patient's moving, the sheet's going to be all messed up. I'd rather see the sheets messed up than tidy. Okay, but I remind myself this phrase that's in Spanish: "Cada persona es un mundo." Each person is a world. Cada persona es un mundo. If I remind myself each person is a world, this is a patient who has likes and dislikes: music, literature, food, hobbies, pets. And what I do is I remind myself every day, ask them, what are their pets' names, their hobbies, their musics, their food. And if I can learn just a few things about this person, either from the patient or from the family members, then I will think of them as an entire person, as an entire world. And I'll say to myself, gosh, I want to know more. Like, why do you like Shakespeare? Why do you like U2? Why is your pet's name Bacchus, the god of wine? You know, let me learn more. But if I can't talk to you and look you in the eyes and make this eye contact, I can't learn more. So my desire now, in service of this human being, cada persona es un mundo, is let me wake them up. Let me get them out of the bed. I want to see the entire person here. And this is the love of the human. This is the humanism. This is the love of being a person, a member of the human race, and seeing another suffering human and saying, I want to reduce their suffering and bring them back to be an entire person, not just somebody attached to a ventilator. What are you thinking, Kaylee?
Absolutely. I think that approach is how we combat our culture. The value in your book, sharing patient stories, as I've done throughout the podcast and my own experiences with interviewing survivors, that has changed my perspective. As I talk to podcast listeners, teams that I've worked with, the balance between the data, the vast research that's out there, and then the real human stories, that is how we change our perspective on our normal practices. So we talked about the fear of patients self-extubating, how scary it is to walk patients. We make a lot of our decisions out of fear. We're practicing a lot of fear-based medicine, not evidence-based. Yet, when we really understand the evidence and the patient perspective, we continue to have fear, but the fear shifts to fear of the impact and harm of our normal practices. Mm-hmm. We become more afraid of sedation, more afraid of immobility. We don't say, what if they self-extubate? We say, what if, like Dr. Ely tells a story about a nurse saying, what if they don't walk again? What if they end up spending days to weeks to months longer on the ventilator? What if they have to have a tracheostomy and go to LTAC? What if they never go back to work? What if they can't provide for their family? What if they lose quality of life? That should be what we're afraid of. And statistically, that is much higher than the risk of self-extubation. But I think from an RN perspective, which I'll get into in, our personal interview, but I think a lot of that fear comes from what we experience when patients have delirium. When we start to sedation and they're on sedation for prolonged periods of time, and now their ventilator settings are minimal. Now we turn down the sedation and they come out agitated, thrashing. They are trying to self-extubate. That is a different experience than an awake and walking ICU, where patients wake up shortly after intubation. They can be reoriented. They can be calm, cooperative. They protect their own endotracheal tube for the most part. Of course, there are other causes, delirium, encephalopathy. They can't have confusion. And that's when we really work hard with family and we take non-pharmacological approaches. We can even do some light sedation. We can do other approaches. But as an RN in travel nursing, I experienced that fear and that stress of having to wrangle a patient that's delirious and trying to self-extubate. And so we have to be more afraid of our current practices and then educate our patients, each other, our colleagues, the families. Patients should be in the loop about this.
Kelly, let me tell a story.
Yeah.
Let me tell a story. I was in Korea. This is a global problem, my friends. I'm in Korea. I'm at this big medical meeting, and there's probably 200, 300 intensivists and nurses in this room. And they bring in this woman. Her name is Yuhan Kim. And she's 27. She's in a wheelchair, and she was in the ICU 2 years ago. Came in perfectly healthy, but she had idiopathic pulmonary hemociderosis. She bled in her lungs, which is to say that she had one organ disease. Everything else in her body was totally fine. She had no disease anywhere other than her lung. Okay. So this is as pristine of an experiment as you could essentially do in the human race. No other organ damage. And I said to them, she was in a wheelchair 2 years later. I said, why is she in a wheelchair? And I lifted up her leg, and it was just a femur with no muscle. And I said, what happened? She goes, I was in the bed for so long in the ICU, I lost all my muscle mass, and it's taken me 2 years, and I still haven't built it up enough where I can walk anymore. And I said to the doctors, why did you keep her sedated and in the bed for so long? And they said, we were afraid she would self-extubate. And another doctor from across the room said, well, what if she never walks again? Wow. And I put that in the book because this is what we have to do, is re-gear what we're worried about. Are we worried about this immediate problem of this one plastic tube in their mouth, which we can put back, by the way? Or are we worried about ruining their life? During COVID, I had a woman, this is amazing. COVID, people say, well, okay, that's all great, but COVID is different. Woman had just delivered her fourth baby. I was the attending. She came to our unit because she had COVID and ARDS. Her baby was in the NICU. So Matt, where you used to work. And the other three babies and the husband were at home. And the woman was on propofol, fentanyl, and had 80% FiO2, peeps of about 18, big time ARDS. The next day we walked in and I said, Brooke, the nurse who I knew well, said, Brooke, we got to turn the sedation off and wake her up. And Brooke was like, really? Because this is a lot of ventilator support. I said, well, let's try. Let's get her FiO2 down. So we got her FiO2 down to 60%, and she desatted down to around 88, 89. And I said, turn the sedation off. We're getting her out of the bed. And she said, why? And I said, because she's got to live and take care of her kids. And I'm going to there's a fallacy in pulmonary that the pulse ox has to rule the day, as if the lung is the only important organ. We have ruined our thinking this way. Why can't we take this woman's pulse ox, let it go to 85, 84 for 30 minutes to an hour, let her see her husband and remember, oh, this is why I need to live. So her husband comes in the room, he's all PPE'd up she's in COVID. We're all in PPE, and she says, honey, he says to her, honey, you're going to make it through this. She opens her eyes, she looks at him, she's cognitively aware. This is my husband. I've got 4 babies. One's in a NICU. This is why I need to live. She gets all of her reason to live back again, her why. That's why she lived more than anything I ever did with the ventilator or her antibiotics.
And Wes, can I ask you, just since we're on an RT podcast, how and why did we allow ventilator settings to dictate sedation practices?
Yeah, so here's what I think happened, but I'd love to hear from the respiratory therapist too. By the way, I've got this famous book here. This book is called Respiratory Care by a very famous guy named Henry Pontoppidan. Pontoppidan, I gave the Pontoppidan lecture at Mass General Man's Greatest Hospital in Boston, and he signed this years later. He's passed away, God rest his soul. He signed it. You can see his signature. He had bad Parkinson's. He couldn't really write anymore. His neurological disease had progressed. And he wrote 3 famous articles in the New England Journal in the 1980s on ARDS. People know these articles. These are the famous Pontoppidan Part 1, Part 2, Part 3 of ARDS. Write that down for anybody listening. Pontoppidan. 2 P's. Pontoppidan. H. Henry, first name. Look up ARDS, him, Part 1, 2, 3, New England Journal. When I was going to give the Pontoppidan lecture at Boston, I pulled these articles, I reread them. I'd read them as a fellow, and I did this around 2010 before he passed away. And what I noticed, Kaylee, was this. The only organ mentioned in these 3 famous papers was the lung. Nothing was mentioned about the brain, the muscles, no other organ. It was just the way that we thought back then. They come in with lung disease. It's a lung disease problem. Let's only focus on lung physiology. Everything has to be geared toward the lung. It's wrong. It's absolutely wrong. This is an entire human being we're dealing with. We cannot only think of the lung, and it's wrong. And you think of a pulmonologist, this is heresy. It's wrong to make the lung trump every other organ.
And in my experience, I've walked many patients on a PEEP of 18 and 100%. It's very customized to each patient. We assess the whole body. And in truth, even working in the COVID ICU, most patients were awake and walking throughout their time in the ventilator. They sometimes had to take a pause. If they could not oxygenate with movement, that was the threshold, obviously. They had to be prone, paralyzed, but they were walking up until that point and shortly after. And tracheostomies were very rare. Death was not at the rates that we were hearing around the country. So then now as a consultant working with teams, the normal protocols indicate that you can't even do a sedation vacation in some ICUs until FiO2 is less than 60%, PEEP is less than 8 or 10.
That's so crazy.
It's not evidence-based.
No.
But yeah, it's in their written
protocols. We have no
protocols.
data to support that anymore. We've debunked that already.
Thank you. I love hearing that from other people, not just me. Sometimes I feel like the crazy person, right?
So we have debunked that. That is old
Absolutely.
news. That is 1990s medicine.
100%. And I think that's where we get stuck. We all want to be the very best that we can. So the data that we learned, the place that we learned as a fellow or as a resident or as a young nurse, we're like, that is a good place. And I can say this because my instructor's on this line, that I learned from this, but things change, but we're afraid. The one thing I wrote down here is fear. The fear of doing bad can potentially cause bad. The other thing is siloed medicine. We look at the lungs, and we as respiratory therapists, and this is controversial, and I'm going to say it anyway. We as respiratory therapists look at the respiratory system and we're going to fix that lung, but we don't think about the bigger picture. And those respiratory therapists that do think about the bigger picture are collaborative, work with the physicians to understand kidney function, brain function, and how the lungs are taking care of that patient are the best respiratory therapists. And I'm seeing my wonderful instructor shaking her head, but Dr. Ely, I think that you would agree too, when respiratory therapists are part of that bigger team, that they are more value added.
Well, let me build on what you're saying.
Please do.
It's even bigger than that. Respiratory therapists are the experts of the ventilator, just like the nurses are going to be the experts of mobility and the drips. Okay, but we have to de-silo these worlds. And yet at the bedside, there's nobody less afraid of a ventilator than a respiratory therapist. The respiratory therapists feel comfortable with this machine. So if they are evincing pain, if they're evincing fear, if they're showing fear, then everybody else responds around and backs off and says, well, the therapist doesn't want to do it. I'm not going to do it. So the therapist becomes the rate limiter in this. Let's flip it around. Let's say the therapist says, you know what? This is a death box here. I'm glad we put it on board, but we got to get it off as quickly as possible. And it's my job to urge you to stop the sedation so that I can try and get my patient off this death box. And let's walk them. If they fail that SBT, then I need to get them up working with a nurse to walk these people so that they don't get so decrepit while they're on the vent that they lose all their intercostal muscles and they have no strength anymore to wean off the vent.
Bingo.
Boom.
Bingo. Oh,
I've seen in teams that I've worked with, especially one in Denver just recently, the RTs initially were pretty hesitant when I did some on-site simulations with them, and they had some valid concerns. It was new. Again, they felt overwhelmed by the staffing ratios, which again had gone back to pretty much pre-COVID ratios, but still that mentality was there of this crisis mode. And they had never experienced this before. They didn't know how it was going to work. Anyways, I went back months later, and the RTs were some of the biggest advocates. Being in the bedside and watching the RTs collaborate with OT, PT, with the nurse, they were so supportive, and they would be the ones suggesting to get the patient up. But the patient was agitated. They say, "I'm here. Let's set him up at the side of the bed. Let me help you." And it would change everything. And then it was just interesting to sit with them at this group of RTs and talk about how this has impacted their role. And they said, we were really incredulous at first, but now we have less ventilator days. They wean off their ventilator settings, decrease sooner, less VAPs. They're more compliant, easier to deal with after they get off the ventilator because the delirium is less. Everything is easier, and we love this approach.
And
But
the
it was
beauty of
awesome to
this
see RT
today,
take a
the beauty of
stewardship.
having you here, Kaylee, is we have to have the therapists and the nurses intersecting on this message. We need Kaylee, you and your messaging to intersect with these strong leaders in respiratory therapy, so that we can, if nothing else, shame the doctors like me out of giving so much damn sedation. Sorry for my French, but I mean, the doctors think that this is the way to do it, and they have to be untaught by you, strong respiratory therapists and strong nurses, please.
So that is a perfect point, and a great segue, because the RT-RN relationship is vital. I have a couple really good friends, and one of our people in medical affairs, Dr. Kirk Hinckley, worked in the military. And when he's doing rescue operations and he's doing flights, there are three people that matter: the doctor, the nurse, and the respiratory therapist. Those three people in emergency and critical care are the most important. And it's sad, and you guys might not know this. I could talk to my respiratory friends. The value of the RT, what Kaylee just talked about, is invaluable. It's perfect. But yet we are valued in a different way by hospital administrators. Hey, multidisciplinary rounds are really important. Guess what we get for productivity? 0. And we talk about those things. And I think that this is important. This is not a popular subject. But the constant good is physicians, nursing, and respiratory therapy working in tandem to make that person better. And that's what should matter more than anything else. It matters. The statistics already show that that's important, but it also tells the stories. We talked about statistics. We talked about stories. Both of them matter. So I'd like to go just a little bit into that. Is the human condition. We feel like we have to save everything. We're taught we have to save everything, but that's not always the patient's expectation. You learned that, hey, I need to know who this person is that I'm saving. I need to know their pet. And will admit, I learned more about their lung disease than I learned about them as a human. So how do we change that in healthcare? Because this is a monumental task and something that's very different than what we're used to. So I'd like both of your perspectives. First, Dr. Ely, how do we change our perspective on taking care of humans rather than bodies?
Well, my mind is going back to a dear friend and patient of mine, who I got to care for. She's in the book, Maya Angelou. Maya was a patient of mine. She was trying to write a poem for the inauguration of Bill Clinton. She was having some lung problems. We were able to care for her. Later in life, she was teaching her son, and I met her son, Guy Johnson, and I asked him, Guy, what did your mother teach you? And she said, well, she said, son, and this is the only place in the world that this quote exists, is in Every Deep Drawn Breath. She said, son, I write from the Black perspective, but I aim for the human heart. And the reason I bring that quote up is this. Each of us brings our own individual perspective. Maya was a Black woman. She wrote from the Black perspective, but she aimed for the human heart. I am a white, gray-haired man. I bring that into the ICU with me and all of my own prejudices, et cetera. Each of us has our own socioeconomic strata, our educational levels, our family traditions. We're bringing all that in, but each of us is a person. And Maya's quote about aiming for the human heart is, to me, how we anchor what we are going to do now as we rebuild humanism in the ICU. And to be specific about that is that the bundle is the toolbox by which to do that, because this 6 steps basically says every patient, every day, no matter what their color is, no matter how poor or rich they are, no matter how educated or uneducated they are, we are going to basically level the playing field and say that all ICU patients should every day be approached with pain management first, and then awakening and turning off sedation, trying to manage their delirium so that I can understand who they are and talk to them using the Dr. Dre, which is diseases, drug removal, environment, this simple little mnemonic of how to approach delirium, and then early mobility and family. And if we take that 6-step approach, everybody gets the same care. It's all evidence-based. It's all humanistic. And what we do is we bring science and technology right up against human touch. So it's touch and technology, which are siblings. And that's what we have to do. It's not just about technology, it's about touch and technology together. That's the way I try and be as a doctor now in the ICU.
So Dr. Ely, I want to talk about just briefly, Kaylee, I'd love your perspective, but I see my really good friend at the bottom, Dr. Mike McQueen, nationally known neonatologist, personal friend of us and here at Vapotherm. When we talk about human touch, as a NICU therapist, kangaroo care, skin to skin contact, what it does for the F in the ABCDEF bundle is huge. And what we know is it decreases the need for sedation. It helps increase that bonding between patients. And when I spent the majority of my time in the NICU and seeing that and families involved in rounds, and I'm like, oh my God, that is so precious. But when I see it in an adult intensive care unit where it's so embedded in tradition, and this is how we've always done it, and they've taken that innovative approach, it makes me feel good, like in the NICU. So that human touch matters. Kaylee, thoughts?
Absolutely. I think one of the biggest barriers to all of this, and the most potent way to dehumanize a patient, is to sedate them.
Oh, say that sentence again. Say that whole sentence again. The most potent way.
The most potent way to dehumanize a person is to sedate them. Wow. You turn off their brain, their ability to communicate, their ability to express pain, their ability to tell you who they are, what they need, their wishes and their care. You turn all that off. Then that is how we create bodies in the bed. I think after working with teams and talking to dozens of clinicians, that is one of the biggest contributors to the moral injury that experienced during COVID. Not just the death, but the dehumanization, working so hard to care for atrophying bodies in the bed. I've thought of a story that just keeps coming to mind. I had a patient with interstitial lung disease, and this is pretty early on in my career as a nurse, and they wake and walk in ICU. And I didn't realize until years later how significant this experience was, because this is very normal in that ICU. He had interstitial lung disease. He was intubated for a prolonged period of time, and it became very clear that it was end-stage interstitial lung disease. He was not going to get better. And but when I first started taking care of him, I took care of him for weeks. We really tried to stick with the same patients unless we needed to switch. And I asked him right away what his favorite song was, because I love to sing to my patients. And he told me, he wrote it down on a board, and I got to know him and what he liked. He liked the temperature of water that he liked down his feeding tube, things like that. I understood his family. He wrote on the board the entire time. He walked, even on higher ventilator settings. He never became delirious. He really wasn't anxious or agitated. So after caring for him for weeks, I really cared about him and his family. And I had just sacred conversations with him and his wife about the reality of his condition. And because he was able to be a part of that, he was able to support his wife during that process as well. And I was on a night shift and I heard it like 4 a.m. clicking at the bed, and he could use a call light, but it must have slipped out of his hand. He was knocking his pulse ox against the rail, and I ran in there and he was agitated, and I'd never seen that before. And I was trying to readjust him, fluff his pellet, do all these things to make him comfortable. And he grabbed my hand and he pulled me in closer to him to make sure that I had eye contact. And he mouthed, "I am dying." And I looked at the monitor and nothing had changed. There was no sign of him dying. And he said again, mouth again, "I am dying." And I said, "Are you telling me that you're dying?" He said, "Yes." I said, "Are you saying that you're ready to go?" And he said, "Yes." And his wife was asleep on the pull-out bed in the room. And I said, "Do you want me to wake your wife up?" And he said, "Yes." So I went and woke his wife up and I said, "Your husband wants to talk to you. I think he's ready." And she went over and I left the room, and she told me later that he said, "Are you going to be okay? Are you going to be okay without me?" He said, "Yes, go home to our son." They already had a son that was waiting for them on the other side. And then I came back in and she said, "So how do we do this?" And RT came in, we gave him medications, did the terminal extubation, and I was able to sing his favorite song to him, his favorite hymn, as he passed. And his wife, he was able to kiss his wife as his hypoxia worsened. That would not have happened if he had been immediately sedated. He would not have been able to call his own shot. His wife would have been left with that decision on whether or not to terminally extubate him. Did he want that? He wouldn't have been able to say goodbye. That only happened because of a humanistic approach of allowing him to be himself, fight for his own life, and call his own shots. And I think about the autonomy in that. That is what I would want for myself. We never go into surgery without a surgeon explaining to us every slight little remote chance. But do we tell patients before they're intubated, if you're sedated, this could increase your chances of dying by up to 68%. You could lose your livelihood, your cognitive function. Life will never be the same if you're sedated, or we can wake you up after intubation and see what you need and let you dictate what you want in your care.
So, Kaylee, Dr. Ely, this is not where I thought it would go, but I'm glad it did. And this is the reason why. I give a lecture with my company, and it's about ethics, and it's about, what do we want as humans? There is no one that says, I want to be full of pain, not being able to speak to my family, not being able to eat, not being able to have an emotional attachment. And I, as a respiratory therapist for way too many years, have always thought that my job was to fix their respiratory problem. It was never a thought until recently in my career that my job is to help the human condition. And that's really, Kaylee, what you're talking about. How can I help them live and pass away the way that they choose, not the way I think it should be? And that's an ego part of medicine that needs to change. So I am so glad that you brought that up, Kaylee. Dr. Ely, amazing. Like, we could literally sit here and talk to the two of you all day. I'm just enjoying this so much. So as we go into a couple things, takeaways, read the book. It'll make you feel good. It'll remind you why you're a caregiver. Second off, Kaylee's going to be on it in a few weeks. Come back and visit her. Okay. We need to continue to have conversations, because leadership is not just about productivity. It's not about how you deliver a breathing treatment, but it's how we care for humans. And that is what respiratory leadership is all about. We care for our patients as humans, but we also care for our people. So the last thing I want to go into anything is, Kaylee, you brought up something that is really important, and I think we need to talk about. And if you have time, I'd like to talk about it. And that's the caregiver human condition. I am a product of burnout at the hospital. I was a respiratory therapy director throughout COVID. I love being a respiratory therapist. I love everything about it. I saw too much pain. I saw things not done the way I wanted them to be during COVID, and I'm a casualty. And I think that because we stepped back in time during COVID is part of the reason why I and others have become casualties. Do you agree, Dr. Ely?
There was one day I was on rounds and I was outside the glass and we were talking about this Hispanic patient and his COVID. He was on the ventilator. His wife was looking in. She was the first family visitor during the entire COVID era at Vanderbilt. And they were talking about his heavy Versed drip and his fentanyl drip, and he was immobilized and he hadn't walked. And I just closed my eyes and I just thought to myself, this is too painful. I've gone from 2022 back to 1990. I've gone back 30 years and we're practicing the same way we were back 30 years ago. I cannot take this anymore. This is so frustrating. And I've done all this work and all of the rest of us have. And I was just like, screw it. I'm just quitting. This is so damn sad, but we can't. And you have chosen to do some new things with your career, and you've gotten us together here today. So your burnout pushed you to get us together today so that we can have this conversation and be honest about where we are with our vocations. You know, I believe in the vocation of medicine. I believe that we were called to serve other people. And I do think that if we don't take care of ourselves, we won't be able to take care of other people. So yes, the caregivers, that means the wives and the husbands, but also means the nurses, the doctors, the respiratory therapists. We have to realize that we will not continue to be good providers for other people if we don't take care of ourselves first. And here's what I want to say, and you may be surprised by this is where I was going with this. The ABCDEF Bundle, my friends, is a burnout prevention program. The reason is because somebody wrote in there earlier, I haven't been able to keep up with all the chat, but somebody wrote, well, the respiratory therapists are going to have to spend some more time. Yes, you will have to spend some more time. The nurses will too. We're not pretending that there's no extra effort here. What I'm saying, though, is that by looking somebody in the eyes, kneeling at their bedside, waking them up and having to deal with the fact that they're awake, getting them out of the bed, walking them, this takes a little extra effort. What you get in return is way bigger than the extra effort. You find your place again in medicine and why you were there, and you yourself are healed. Not just the patient is not just healed, but we are healed by knowing that we're doing right. I walked around with shame and guilt in my heart and chest pain because I knew that I was not doing right by my patients. And I discuss this a lot in every deep drawn breath. I will say one last thing about this because we're running out of time. In the paperback, there's this gold emblem on the paperback. It stands for the Christophers. The Christopher motto is, it's better to light one candle than to curse the darkness. And they gave Every Deep Drawn Breath this award in 2022 for that motto, because this message that we're talking about here is lighting a candle instead of just cursing the darkness and burnout. So, you know, that's why the message of this is one of rebirth and joy and hope. And we cannot give up that hope. Instead, we can use the data that we've generated in the past 20 years to find our way again and to find that joy and that hope in medicine.
So, Kaylee, I'm going to hold you off because I am so excited for us in a few weeks, and I can't wait to talk. And you and I and Anna will talk very soon because I will be your host in a few weeks. Dr. Ely, one of the things that, you know, when we talk about burnout, it's very easy. Here's a pizza, have a good day. One of the things that you did was you kept a journal. And in some part of your mind, when you were in New Orleans, you're like, I'm going to document my journey. And to me, as I read it, and Anna put it in the notes, it felt therapeutic for you. It seemed like that reflection and being able to look at that mattered to you. Is that why you kept your journal? Maybe it was even subconscious.
I think that pain's got to come out somewhere. And when we pretend that we can put pain in a box, whether it's pain of a broken relationship, of a patient dying, of me making an error in medicine, of me not raising my daughter right. All these aspects of pain, we are people, and we cannot just take that pain, put it in a box, throw the key away, and think that that's been processed. So my writing is my processing of the pain. And I take my brain and my heart, and it comes out my hand, and I think of myself as a pencil. So I listen to people's stories, and I write them down, and that's how I process my pain. And thankfully, over the years, Rena Oddish, who wrote In Shock, said to me, Wes, you need to write a book about this because you can help us through patient stories to understand, the evidence. So what I did was I said, we generated the evidence. We've published in the New England Journal, JAMA, Lancet, and it's done some good, but it's not enough. So we've got to put the patient stories back together with those data. And thankfully, I had all these stories written down. And that's what EDDB is. It's a narrative nonfiction book. It's not a memoir. It's really about these people and their stories. And I hope that their bravery and what they contributed to medicine is what can help, be one of the widgets that helps us get back.
Wow. So like I said, we could talk to you guys forever. We're about an hour in. A couple takeaways that I got that I want to repeat. Everyone's an individual. Everyone wants different things out of life, and it's our job as healthcare providers to do what we can, whether that's less sedation, less ventilation, or dying peacefully. Thank you, Kaylee, for your talk about that. Another thing that we could definitely talk about in the future, and Anna, I know you'll write this down, is treating to the number. Treating to the number is a waste of time. Treating to the patients and their expectations and their desires is something we need to do, but we're very, very good at treating to the number. So as we finish up, oh my God, what a day. I've enjoyed this so much. You've made my heart feel good. Thank you, Dr. Ely. Thank you, Kaylee. Thank you, everybody that's on. Before we go anywhere, Anna and I have some huge shout outs to huge people here. First off, big shout outs to everyone that's on today. Dr. Wes Ely, Kaylee, thank you so much. We have a shout out to Bernadette, New York, one of our greatest CEs here at Vapotherm. Best RT out there. Happy birthday.
And shout out to Butler, our other co-host who wasn't able to make it today. Happy birthday. We can't wait to celebrate with you next week.
Congrats to Taylor Troy, Amy Burjeski, Jeannie Pedanici, and Dorota McKay on their promotion, and all of those here at Vapotherm that got promoted. Well deserved. Thank you so much for being great teammates.
And by the way, guys, any money that comes about from this book goes back to patients and families. 100% of the proceeds are going back to patients and families. Help draw people in. Go to Amazon, Goodreads, leave a review, a book recommendation, and let's draw people into this story and let's rehumanize.
I love it. Dr. Ely, Kaylee, any shout outs for you for the podcast?
I'm thankful to you all.
Thank you so much. Kaylee, anybody?
I've included links to relevant podcast episodes. I have 115, soon to be 125 coming out. So there are a lot of resources. If you go to my website, DaytonICUconsulting.com, under the resources tab, there is a podcast for clinicians and a podcast for families to help educate families about this, to save you time at the bedside. But the clinician podcast, if you scroll down to the bottom of that screen, these podcast episodes are organized by topic. So if you want to listen to survivor testimonials from survivors that have been sedated, as well as survivors of awake and walk in ICU, hear from other RTs.
And what's the name of your podcast?
Walking Home from the ICU, because that is the goal.
That is the goal. That is the goal. Thank you
Kaylee,
so much.
I'll be including that in the show notes. So you'll be able to find a link to her site and her podcast, as well as the book. So if you haven't gotten from today, not only as a provider should you read this, but as a caregiver, right? Because this is such a prevalent situation where 6 million Americans a year have to go into the ICU for whatever reason. Which I think you've helped teach me today of like how I can advocate for a family member if they were ever to have to go into ICU. So I'll include all those things in the show notes. Thank you guys.
Thank you.
Awesome. Anna, to you.
Bye, everybody. Thank you.
That's it for this week's RT Sidebar. If you liked what you heard today, Share, follow, like us wherever you get your podcast. That truly helps us grow. Better yet, join the live recording by registering with the link in the show notes. You can also leave a topic suggestion for our next show with the link in the show notes. Thank you, and see you next time. Vapotherm does not practice medicine or provide medical services or advice. Any clinical recommendations provided herein are solely those of the speaker. Practitioners should refer to the full indications for use and operating instructions of any products referenced before use. The team behind the sidebar are employees of Vapotherm, and our guest is not compensated.